if we shift this over a little bit into sports, and particularly into contact sports, I know, a few years ago in the NHL, there were some tragic cases of player deaths with opioids combined with heavy alcohol consumption. Can you speak to how that can be a potentially really dangerous combination?
So that's really one of the big things with opioids. So as we've seen this big uptick in opioid-related harms and deaths, and the majority they all involve opioids, but the majority involve other substances, and particularly sedating substances. So sometimes therapeutic and sometimes non-therapeutic. So alcohol is a big one. Benzodiazepines, which are medications used to treat things like sleep and anxiety, are another big one. And there are also pain medications like gabapentin. Gabapentin, a recent study demonstrated that people who are on both opioids and gabapentin had about a twofold increased risk of overdose as compared to people who are just on opioids. So it is certainly the combination and different contexts, whether it's sports or other kind of social contexts, can increase the risk of exposure to other substances besides opioids. And when we're talking about contact sports, of course, high risk of injury, and perhaps a lot of pressure to be able to return to play. And there was a time, I suspect that has changed, but there was a time when opioids were considered a reasonable way to be able to fight pain, workplace related pain, and be able to return to work and return to sport.
Yeah, it's amazing how not too long ago that was definitely something that was more readily used. And in our chat before the interview here, we mentioned even on the collegiate level as well. This is something where, especially college football being so popular in the U.S., that the return to play and the pressure to perform sometimes leads people to choosing these alternatives.
Choosing the alternatives, or maybe even feeling coerced.
Probably a better word.
given all the pressures to perform and succeed, and I would say probably beyond that too, not being well informed of the risks. We didn't communicate as a profession. Have not done a good job of communicating with our patients, at least historically, about the potential risks of opioid therapy.
I recently, had a chance to hear you speak at the Integrative Health Symposium in 2016 in Toronto, and you talked about how, in science we can differentiate between pain intensity and how much pain's actually bothering you. You actually used a great quote, yoga quote: "Pain is inevitable, but suffering is optional." How is suffering intertwined in this sort of pain management and chronic pain piece?
I think very tightly interwoven, and this goes back to some of the moral arguments that I referred to earlier about our responsibility as healthcare professionals. And, I think part of our calling is really to reduce suffering in the world. And pain can be at the root of suffering, or can be a proximal driver of suffering, but can be distinguished from the two. And I think that perhaps is where we lost the plot with respect to chronic pain and with opioids. We have reasonable suspicion, or we know that in some circumstances opioids can help to reduce pain, but do they reduce suffering is certainly an open question. And there's no way that I'm denying that there are some people, I have patients myself, who have benefited from long-term and in some cases high-dose opioid therapy. So I'm not a quote-unquote opioid-phobe, but we're trying to bring the balance back. And very interestingly, as our knowledge of how our mind works and how our brain or nervous system works has continued to evolve, we've been able to find ways to distinguish between pain intensity and pain suffering. we have different measures that can help distinguish between the two. We know that different regions of the brain potentially mediate these two things differently, that we find different areas of the brain being involved in pain intensity versus pain bothersomeness, which I really equate with the suffering component or the emotional component to pain.
For sure.
And, in an ideal world, or what we are called to do is really help with both. And that if we only help with one, or particularly help with the one that patients are coming to us with, I think there are a lot of people out there who live with pain and don't present to healthcare providers. But people, because they're not suffering. I think the people who present for healthcare with pain are the ones who are suffering. And so it is our responsibility really to treat what they're coming to us for and address their suffering. And so if we can find ways to do that, our healthcare system, our patients, our society will be better off.
100%. And this is where, for me, and I'm sure likewise for yourself, this, in terms of modalities and things that can support, this is obviously, meditation, breathwork can play a massive role. You've written here that, meditation, or folks who meditate have thicker brains compared to pain sufferers. So can you explain that to folks and maybe tell us where we're at in terms of the research on meditation and pain?
Yeah, so I think one of the very interesting things about meditation. So there's been, I'll talk about a few things. One is we have fairly good quality evidence that various forms of meditation are effective in reducing pain, chronic pain specifically, and this is better quality evidence than we have for opioids. People who have chronic pain, often there is a suffering component. Often there are associated psychological symptoms like depression or anxiety or insomnia associated with their pain. And so, one question has been asked is, how much does meditation actually improve pain intensity versus all these other things that go together with pain? And we have, again, pretty good evidence that meditation actually reduces pain intensity, so the actual experience of the pain, and can impact the psychosocial symptoms and the pain bothersomeness. And so there have been some pretty interesting studies looking more in the acute pain realm, looking at how meditation can mediate these kinds of things, but we can actually distinguish between the pain intensity and the pain bothersomeness and see actually how meditation can affect both. One mechanism, and it's an open question what the underlying mechanism or mechanisms are. One of them is we do know that the brain is plastic, meaning it can change as a result of experience. And one of the very potent ways of doing that is meditation. And interestingly, we find there have been some very neat studies looking at long-term meditators and how their brains compare to non-meditators or more junior meditators. And as you alluded to, one of the findings is changes in cortical thickness. So a particular part of the brain actually grows in mass and becomes larger than it does in non-meditators. And this is important. I mean, generally, I guess when we think about brain tissue, the more the better. But that's actually not necessarily the case. But what we find is in people who have chronic, for example, low back pain, they have cortical atrophy. So in parts of their brain that mediate the interpretation of sensation, they actually have less brain mass. And so you see the corresponding right thing happening in people who meditate. They get more brain mass. But there's another area of the brain besides the cortex, which is the thalamus. And the thalamus is sort of the gateway of sensation, one really important sensation processing center, not just pain, but the other senses as well. And in people who have chronic pain, you actually see an increase in activity and mass in the thalamus. And but in long term, in people who've had some experience with meditation, you actually see less activity in the thalamus. So it's not just that meditation changes the brain, but meditation seems to change the brain in ways that are highly relevant and important for the mediation of pain.